All right, let's dive right in. Today, we're going to crack a clinical case that you will absolutely see in your career, where a bunch of seemingly random symptoms all point back to one single underlying problem. We're breaking down hypercalcemia.
So where do we start? Well, like with any good clinical puzzle, it all begins with a patient. Let's set the stage with a classic presentation that's a favorite for exams. So picture this. A patient comes to you, and their main complaint is painful kidney stones. As you dig a little deeper, they mention they've also been feeling kind of confused lately. They're really backed up with constipation, and they're going to the bathroom to urinate way more than usual. Now, on the surface, those things sound totally unrelated, right? Kidney stones, confusion, gut problems. But what if I told you there's a single diagnosis that perfectly explains every single one of them? The answer is high calcium.
Okay, so the big answer is hypercalcemia. But what does that actually mean? Before we can go any further, we have got to nail down a clear and precise definition.
So by the book, we define hypercalcemia when a patient's serum calcium level gets above 10.5 milligrams per deciliter. That's our magic number. It's the fundamental threshold that tells us we have a problem. But wait, there's a huge catch here, and it's a classic exam trick. A lot of the calcium floating around in our blood isn't free. It's actually stuck to a protein called albumin. So if your patient's albumin is low, their measured calcium could look falsely normal or even low. This is why you always have to calculate the corrected calcium. And this is the formula you absolutely need to know to do that. You take the calcium level from the lab and you add 0.8 times the difference between a normal albumin of 4.0 and whatever your patient's albumin is. It sounds complicated, but it's essential for getting the true story on their calcium status. All right, so we've defined the what. Now for the million-dollar question. Why is it happening? What's actually driving that calcium level sky high? When we think about the causes, it's like a fork in the road, and the signpost at that fork is one key hormone, parathyroid hormone, or PTH. We can split all the causes into two big buckets. Is the problem PTH dependent, meaning too much PTH is driving it, or is it PTH independent, or something else is to blame? You can see right here, the number one cause you'll see in the clinic, primary hyperparathyroidism, is PTH dependent. But the most common cause for a hospitalized patient, malignancy, is PTH independent. So if there's one thing you write down for your exams, it's this. It's a simple but incredibly powerful rule of thumb. If you see a lab report with high calcium and you also see a high PTH level, your diagnosis 9 times out of 10 is going to be primary hyperparathyroidism. So we've gone from the lab values to the causes. Now, how does this all actually show up in a person? Let's connect this back to our patient from the beginning, because there's a classic mnemonic that captures all of this perfectly. This brings us to that famous mnemonic: stones, bones, groans, thrones, and psychiatric overtones. First up, stones. This one's pretty straightforward, right? It's the kidney stones, caused by all that extra calcium trying to get out through the urine. That was our patient's number one complaint. Next, we have bones. Now, where do you think all that extra calcium is coming from? A lot of the time, the body is literally pulling it out of the skeleton, which can lead to bone pain and even fractures down the line. Groans. This covers all the belly problems. You see, high calcium slows everything down in the gut. It puts the brakes on motility, leading to that constipation and abdominal pain our patient was feeling. Thrones. This one's a clever one. It refers to sitting on the toilet. The high calcium levels mess with the kidney's ability to concentrate urine. This leads to polyuria, frequent urination, which can make the patient super dehydrated. And finally, psychiatric overtones. This is huge, and it directly explains our patient's confusion. But it can be a whole range of things, from mild depression or anxiety, all the way to a full-blown coma in really severe cases. Now, besides what the patient tells you, there's a really important objective clue we can find on an EKG. High calcium actually speeds up the repolarization phase of the heart's electrical cycle, and what that does is it causes a characteristically shortened QT interval. This is a very, very common exam question. Okay, awesome. We've connected the labs to the causes to the symptoms. Now for the most important part. What are we actually going to do about it? Let's walk through the action plan.
The diagnostic workup follows a super logical flowchart. Step 1, you've got to confirm that the hypercalcemia is real, using that corrected calcium formula. The immediate next step is the crucial one. You measure the PTH level. This is the big decision point. If PTH is high, you're thinking primary hyperparathyroidism. If it's low or suppressed, your brain should immediately go to malignancy, and you'll start looking for things like PTH-related peptide or PTHRP.
Now, when it comes to managing a patient who's really sick from this, the order of operations is everything. The absolute number one, first line, can't skip it step is aggressive IV hydration with normal saline. These patients are almost always dehydrated. After you've given them fluids, then you can think about adding loop diuretics to help flush the calcium out. Then you move on to drugs like bisphosphonates that get to the root of the problem by stopping the bones from breaking down.
Okay, that was a lot of information, so let's just boil it all down. If you're studying for an exam and you remember nothing else, remember these 4 things. The most common cause in general is primary hyperparathyroidism. The most common cause in the hospital is malignancy. The key finding on an EKG is a short QT interval. And the very first step in treating a severe case is always IV fluids. And that wraps up our breakdown of hypercalcemia. But I'll leave you with one final thought to really get you thinking. Since we know malignancy is a major cause, how would your treatment strategy change if you knew the patient had a cancer like lymphoma or multiple myeloma, which are often responsive to steroids? Something to think about. That's all for this explainer.